Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Welcome you again to this very fascinating lecture by Professor Ali Zahrani, whom I had great pleasure actually to introduce for the audience. Dr. Ali Zahrani is a well-known figure and one of the most distinguished of his generation of the endocrinologists in our area. He is professor of endocrinology in King Faisal Specialist Hospital and Research Center, and he's an all-round actual endocrinologist. He published widely in many fields of endocrinology, and it gives me special pleasure to welcome him today to give us a talk about new era in management of thyroid eye disease. Professor Ali Zahrani.
Rahim, thank you so much for the opportunity to talk to you today about new era in the management of thyroid eye disease. My name is Alzahrani. I'm from Riyadh, Saudi Arabia. This is my disclosure. So thyroid eye disease is called also Graves' ophthalmopathy, thyroid-associated ophthalmopathy, Graves' retinopathy, and different names. But at the end of the day, probably the best term is thyroid eye disease. It occurs in patients with hyperthyroidism in around 85% of the cases. However, it can sometimes occur in patients with hypothyroidism and euthyroidism. Those patients usually have Graves' disease and were treated. And some of them also, they may have Hashimoto's or Hashimoto's thyroiditis, because all of these diseases are autoimmune. So occasionally you can see Graves' ophthalmopathy in patients with Hashimoto's thyroiditis or Hashimoto's, or in patients who receive radioactive iodine in the past or underwent surgery. However, as we just mentioned, and as the name implies, Graves' disease is a Graves' ophthalmopathy or thyroid eye disease is associated mostly with Graves' disease. Now, it is not uncommon. However, most of the cases are mild, and sometimes they are unnoticed especially if the physician is not experienced or not examining the patient very carefully. However, they are frequent, occurring in as high as 45 to 60% of cases. Some facts about thyroid eye disease, as we just mentioned, it occurs with Graves' disease. However, it is a distinct disease on itself, and it may cause irreversible damage even if you control Graves' disease. Thyroid eye disease more commonly affects women than men. The age-adjusted U.S. incidence is around 16 cases per 100,000 per person per year in women, and it is around 3 cases per 100 persons per year in men. The peak incidence in women is usually earlier than men, occurring in 2 peaks, 40 to 44 years of age and 60 to 64 years of age. In men, it peaks usually at 45 to 50 years of age and 65 to 69 years of age. The risk factors for thyroid eye disease are classified into endogenous, which are non-modifiable, like genetics, age, gender, and race. As we just mentioned, the genetics obviously is an important predisposing factor. Age, we just mentioned the ages in which this disease peak. Gender, as we just mentioned, is more common in females, and it is very common in European and American, but it occurs basically in every race. Exogenous risk factors include smoking, thyroid dysfunction, radioactive iodine, as you know, may precipitate Graves' disease and may make it worse, although this is a bit controversial issue. Oxidative stress, hypercholesterolemia, and diabetes mellitus are also risk factors for thyroid eye disease. So again, to emphasize the point that Graves' eye disease or thyroid eye disease is not synonymous with Graves' disease. Graves' disease is the thyroid disease that causes hyperthyroidism, and as you can see here, the incidence is much higher than thyroid eye disease, but also thyroid eye disease is not uncommon. The mechanism of disease is different. In Graves' disease, it is a straightforward autoantibody against thyroid stimulating hormone receptors, stimulating these receptors and triggering excessive production of thyroid hormones, while the pathophysiology and mechanism of the disease in thyroid eye disease more complex and involve IGF-1 receptor and also TSH receptor on the fibroblast, as we will discuss in a minute. The course of the disease in Graves' disease, it is relapsing and remitting unless it's treated with a definitive treatment. But in thyroid eye disease, the course is usually acute, followed by chronic disease. It does not relapse frequently, but unfortunately, the severity of the disease in the acute stage is usually followed by complicated chronic disease. Hyperthyroidism is the main feature of Graves' disease, but as we just mentioned earlier, in thyroid eye disease, it can happen with hyperthyroidism, it can happen in euthyroid or hypothyroid patients. So the point here is that thyroid eye disease and Graves' disease are not synonymous. They may coexist. TED may precede or follow Graves' disease, and thyroid eye disease may exist without hyperthyroidism. We just mentioned the course of the disease. This is the course of the disease of thyroid eye disease. It is characterized by acute phase, usually in the first 9 to 12 months, and then a chronic phase afterwards. And the importance of this, that there is what is called window of opportunity for intervention and management and modifying the course of the disease. This is the therapeutic window. It is best and ideal in the first few months, but opportunity continue to happen, although it is narrowed as we move on from the first year. You can see there is still therapeutic window in the chronic phase, but this therapeutic window is much narrower than in the initial phase during the acute phase. This is inflammatory phase, and therefore we can interfere and change it. This is mostly fibrotic phase, where intervention does not have the same positive outcome as in the acute phase. So again, the clinical manifestation reflects the pathophysiology. So in the short term, in the initial phase, in the acute phase, you get chemosis, conjunctival redness, periorbital and lid swelling, pain, ocular dryness, foreign body sensation, epipora, photophobia, and eyelid retraction. The long term is characterized more by fibrosis and less inflammation. So eyelid retraction, proptosis, pain, strabismus, diplopia, decrease in vision, compression of optic nerve, color vision deficiency, and visual field defects. These are some of the features here in photos. So you can see the conjunctiva is red with chemosis. Tearing is very common. Foreign body sensation is usually a feature of this. The eyelids here are swollen and red, as you can see, and there's a lack of thalamus or lid retraction. This can lead to exposure keratopathy. Orbital pad expands and leads to proptosis, disfigurement, squint, keratopathy, visual loss. Extraocular muscle movement are frequently restricted, especially in the chronic phase, and that lead to a squint, diplopia, pain, and decreased vision and perception. And finally, in the very severe cases, you can have optic nerve compression leading to compressive optic neuropathy, loss of vision, and impairment of color vision. The pathophysiology is complex, but what we understand is that the immune system is activated and B cell is converted to plasma cells, and plasma cells, as you know, produces antibodies. And some of those antibodies in Graves' disease include thyroid hormone receptor antibody and also IGF-1 receptor antibodies. At the same time, T cell interact through these receptors with the fibroblast, with the orbital fibroblast, activating the fibroblast. This leads to expression of the IGF-1 receptor and TSH receptor, and those antibodies that are produced by plasma cell bind to this. The activation of the myofibroblast lead to either change of this myofibroblast into adipocyte or change into myelofibroblast, that's basically muscle cells or mesenchymal cells. There is also secretion of hyaluronic acid, which is a material that is that expands basically the orbital tissue. And the final result, you have a lot of tissue in the retroorbital compartment. You have a lot of inflammation and inflammatory cells. And that leads to proptosis, restriction of movement, redness, inflammation of the whole orbit. We evaluate patients for two aspects of the disease, for the activity of the disease, and activity here refers mostly for the inflammatory part of the disease, but we also have another part of the disease, and that's the severity. And we should differentiate between the two. Activity reflects basically the inflammation and the activity of the disease, as mentioned. And the severity, the disease can be very severe, but not active. So how do we assess the activity? The most commonly used system is what is called Clinical Activity Score, or CAS. And as you can see here, it is 7-point score. I usually think about it as 2 pain, 2 redness, and 3 swellings. So pain, retroorbital pain, pain on attempted upward or downward gaze, redness of the eyelid or redness of the conjunctiva, or swelling of the eyelid or swelling of the conjunctiva, and also swelling of the caruncle or plica. So basically, activity more than 3 reflects an active disease. So if the score is more than 3, it is basically an active disease. For the severity, the European group on Graves' ophthalmopathy classify patients in mild, moderate to severe, and then sight threatening or very severe. The mild one are those that have some symptoms, but these symptoms do not justify using immunosuppressive therapy or immunomodulation or surgical treatment. So basically, as you can see here, mild symptoms, mild retraction, soft tissue involvement, less than 3 millimeter exophthalmos, and moderate to severe are more symptoms of these that need actually intervention by either immunosuppression or surgical intervention. So it's basically moderate to severe. So the moderate and severe are included together to differentiate them from the very serious situation of the sight-threatening or very severe Graves' ophthalmopathy that is related to optic neuropathy due to compression or corneal breakdown due to exposure. Now, let's move now to the management. I think we talk about the features of the disease, the pathophysiology, and how to assess the disease. Now, talking about how to manage the disease, the best setup for management is a multidisciplinary team. If the disease is more than moderate, refer those patients to specialized centers. You need to control the risk factors. Smoking is very, very critical to be stopped. Hyperthyroidism or hypothyroidism need to be corrected. Hypercholesterolemia and severe hyperglycemia need to be controlled. Avoid radioactive iodine in patients with severe disease. And if the patient has moderate or mild disease, you may consider going ahead with radioactive iodine. And in the moderate category, you could cover them with prednisone for around 6 weeks using those doses. But in terms of active treatment for moderate to severe disease, this is the latest recommendation from the American Thyroid Association and the European group on study of Graves' ophthalmopathy. they had combined consensus statement that was published in Thyroid a few months ago. And basically, as you can see here, it depends on your goal. So if the goal is to inactivate the disease and reduce soft tissue involvement, IV glucocorticoid is the preferred therapy, but acceptable therapy include teprotumumab and radiotherapy and intravenous glucocorticoid or oral glucocorticoid. And there are other things including rituximab, tocilizumab, and even observation. However, when the objective is disease inactivation and there is significant diplopia, teprotumumab that I will discuss in details is the treatment of choice. The same thing when proptosis is the predominant feature, teprotumumab is the treatment choice. I'm going to call it Tibro for ease. Eye motility improvement, again, any of this, including Tibro, are treatment of choice. So you can see here that the IV glucocorticoid is only indicated for patients with very active disease for reduction of soft tissue involvement, but for diplopia, proptosis, and eye motility, Tibro seems to have now come forward to the forefront. Talking about Tibro, it is fully human monoclonal antibody against the IGF-1 receptor. As we mentioned in the pathophysiology, it inhibits this receptor, it binds to this receptor and inhibits it. It is administered in 8 doses every 3 weeks. The first dose is usually 10 milligram per kilogram, and in the other 7 infusion is 20 milligram per kilogram. In the first 2 doses, we give it over 90 minutes, and in the next 6 doses, we give it over 60 minutes. It was designated as an orphan drug. It achieved a fast track through FDA approval because, again, of the interesting and overwhelming finding or positive finding, and at the same time, the need for an effective treatment for Graves' ophthalmopathy. It's breakthrough therapy designation by FDA because, again, of its very good results. It was approved not too long ago, only around 2 years ago. So as we just mentioned, if you remember the pathophysiology, IGF-1 is very important. IGF-1 receptor is very important part of the pathogenesis pathway. So Tibro actually blocks the IGF-1 and therefore deactivate the orbital fibroblast, preventing them from changing to fat or myofibroblast and decreasing the inflammation overall and the secretion of hyaluronic acid. Let's review the data. The first trial was phase 2 trial in 2017. In this trial, they included patients who had thyroid eye disease between 18 to 75 years of age, less than 9 months, because they wanted to treat patients during the acute stage. And they have active disease, so the CAS activity is more than 3, is 4 or more, and their thyroid function test is within 50% above or below normal limits. They screened them, they randomized them to take Tibro or placebo, 42 patients in the Tibro and 45 in the placebo for 8 injection, 24 weeks, and then they followed those patients for around a year, 48 weeks. The primary endpoint was percentage of participant with more than 2 millimeter reduction in proptosis or more than 2-point reduction in clinical activity score. So reduction in proptosis, a reduction in clinical activity score. So this is again just showing you the primary and secondary endpoints. So there are 2 primary combined endpoints, and that's basically a reduction in proptosis more than 2, a reduction in clinical activity score more than 2. There are a number of secondary endpoints. So what are the results of this phase 2 trial? As you can see, 70% of patients who received Tibro achieved the primary endpoints compared only to 20 in the placebo arm. And the proptosis, which was the main primary endpoint, was decreased in 71% of patients compared to only 20% in the placebo group. You can see that this improvement occurred very early at 6 weeks and continue to be significantly different between the placebo and Tibro throughout the study period. And you can see the same thing here in the clinical activity score. Again, it achieved early and continue to be significantly different between Tibro and placebo throughout the study period. You can see the quality of life, which is divided into visual functioning improvement and appearance improvement. You can see the visual functioning improvement again occurred at 6 weeks and was significantly different between the Tibro and the placebo and continued to be different throughout the study period. This was also different but did not achieve statistical significance. However, the combined subscales were completely different between the Tibro and placebo. Subjective diplopia disappeared or improved in more patients who received Tibro. So you can see at 6 weeks, around 40% compared to only 20%, and around 60% at 12 weeks, around 60+% at 18 weeks, and then around 70% at 24 weeks. Now, what happens after the trial finished? At week 24, they stopped injections and they followed those patients for 48 additional weeks, so a total of 72 weeks. That's more than a year, so almost 2 years actually, or 1.5 years. 53% of patients maintained more than 2 millimeter improvement from baseline. So this is a durable response. 73 had reduced proptosis from baseline and did not receive any additional treatment. Week 24 diplopia responders were 67%, and they were maintained through week 72. And there was no difference between the different subgroups, including age, gender, or patients who were smoker and non-smoker. This phase 2 trial that was published in New England Journal of Medicine in 2017 was followed by a confirmatory phase 3 trial this time that was published again in the same journal in 2020. The design is exactly the same. The number of patients in the Tibro was 41 and those in placebo 42. Again, this is the inclusion criteria: patient with thyroid eye disease, 18 to 80 years, less than 9 months. So during the active phase, they have active disease and their thyroid function is within 50% of above or below normal limits. Randomization to placebo or Tibro, 24 weeks, and then a follow-up period of around 1 year. This is called OPTIC trial, and we look at this. The only difference between this and phase 2 trial is in primary endpoint here was limited to basically proptosis. So basically, they wanted to look at percentage of patients who had reduction in proptosis more than 2 millimeter. And the reason for this is the clinical activity score is a bit subjective and variable between different physicians. And therefore, they wanted to use a very standardized measure. And they chose proptosis, which was excellent. But they had actually several secondary endpoints, as you can see here on the right side, and we'll discuss them in a minute. The results is more or less similar to phase 2, even better than phase 2. So you can see, again, baseline 6 week, 12, 18, 24 weeks, clear separation between proptosis. Patients who achieved more than 2 millimeter improvement were much higher at 6 weeks, 12 weeks, 18, 24 weeks in the Tibro group compared to placebo. Overall, 73.5% of patients who received Tibro had improvement compared to only around 10%. The difference was 83% versus 10%. You can see the same thing here when you combine proptosis and clinical activity score. So overall, 78% achieved that goal in Tibro arm versus only 7% with a difference of 71% between the two groups. You can see here also the improvement in proptosis started very early, and overall there was a median reduction of 3.3 millimeter in proptosis, a difference of around 2.8 between placebo and Tipro. You can see here an excellent example of this patient who had significant, very clear proptosis and chemosis and conjunctival redness and lid redness, and at 24 weeks, he is much, much better. You can see this also on this MRI that shows inflammation and swelling of the muscles, orbital muscles. And at 24 weeks, there's much less inflammation and less swelling of the muscles. These are the patients with diplopia score, and you can see the diplopia score improved at 6 weeks and continued to improve throughout the period. This is a patient at baseline, and you can see at 24 weeks, her eyes are now aligned in the same level, and she has less proptosis on the right side. This is the quality of life. Again, there was a difference of around 16% points between those who received Tipro compared to those who received placebo, both in the appearance and in the visual function. So this is the summary basically of what I just mentioned. So the primary endpoint was proptosis at 24 weeks, 83% in the Tipro improved versus only 10%, clearly significant. The overall response rate was 78% versus 7%. The CAS activity less than 0 to 1, which means inactive, is basically achieved in 60% in Tipro versus only 20% in placebo. The mean reduction in proptosis was only minus 0.54 millimeter versus 2.8 millimeter. And then diplopia responders were 70% versus 30% here. Quality of life, around 14% Tipro versus 4% in the placebo. I will just probably skip this. We already mentioned it. But this is a combined data, pooled data actually from the two trials, the phase 2 and phase 3 trial. And the point here is continued improvement. So this is actually after the trial. So you can see that at 28 weeks, 36 weeks, 48 weeks, 60 and 72 weeks, percentage of patients who continue to have that improvement in proptosis is anywhere between 87%, 91%, 85%, 88%, and 67%. So this is durable response. The same thing for diplopia, the same thing for the composite outcome, that's diplopia and proptosis, and the same thing for quality of life. It was maintained after the drug was stopped. So this is not only improvement during the treatment, but this is a durable response. So at 72 weeks after starting Tipro, and that's around 1 year after finishing treatment, 67% of proptosis responders maintained their response. 70% of diplopia responders maintained their response. 85% of clinical activity score respondent maintained their response status with more than 2-point improvement versus pre-treatment. And patients who received Tipro observed mean 15% point overall improvement in their quality of life compared to only around 4 points in the placebo arm. What about the side effects? Like any drug, side effects are there. However, adverse effects occurring in more than 5% of patients treated with Tipro were actually not significantly different, except that muscle spasms were more frequent in Tipro, nausea, alopecia, diarrhea, and then fatigue, hyperglycemia, hearing impairment, dysgeusia, headache, and dryness. Obviously, they are more frequent with this treatment, but none of them was serious. So there was a low rate of discontinuation. Only 90% of patients with Tipro 90% continue to take the drug, and 93% with placebo arm completed the 8 infusion. Most adverse effects were mild to moderate, manageable, and resolved during or after treatment. There are specific events of interest in phase 2 trial, and that include potential infusion-related reaction, which occur in 6 patients in the Tibro versus 4 patients placebo. Anaphylactic reaction did not happen in either. Hyperglycemia happened in 2 patients in the Tibro, and muscle spasm in 13 versus 4 patients in the placebo, and diarrhea 4 and 5, and hearing impairment in 4 patients versus 0. It's very important for people who are planning or to use those drugs to watch certain situations. So infusion reactions have been reported in around 4%, and the way to deal with them is to basically interrupt or slow down the infusion and use appropriate medical management. Hyperglycemia in a clinical trial, 10% of patients, that's 2/3 of whom had pre-existing diabetes or glucose intolerance. 10% experienced hyperglycemia, so monitor blood sugar and appropriately manage it. More important, if you have a patient with inflammatory bowel disease, Tibro is not a good choice for that patient, so monitor them carefully or don't use it in those patients. And if there is exacerbation, stop it. And then Tibro has not yet been studied in pregnancy and is contraindicated in pregnancy and should not be used. And with that, I stop here. Thank you so much for your attention.
Thank you, Dr. Ali.
Professor Ali Alzahrani, for such a very fascinating talk. We would have loved to take 1 or 2 questions, but unfortunately, because of sake of time, we have to move on. I would like to thank Horizon for supporting the previous lecture.